Good afternoon, everyone, and welcome to taking your telehealth program to warp speed, our breakout for you this afternoon. I'm George Lillig. I'm head of healthcare here at Zoom. Thrilled to be with you. Thank you so much for coming. I'm going to let them introduce themselves in a minute, but we do have Amber from Vanderbilt and Hossam from Regroup Telehealth. I thought I would set the context for a second here about Zoom and telehealth. Hopefully you're enjoying our theme about space and travel and going to the moon. I do have one funny story about that. I have a daughter who is a really good runner, and in high school her PE coach kind of recognized this talent, and he pulled her aside one day after she ran a mile, and he said, "You know what, Colleen? You're really good at this. Instead of shooting for the stars, you should shoot for the moon." I think you might have got that a little backwards, but anyway, he had the right notion. She went on to do really well. So anyways, that's our theme today. Our other theme is gratitude. Thank you so much for being with us. So when we did our first breakout for healthcare at Zoomtopia, that was last year, and I think our notion then was, let's let people know that we're in this space. I think our customers had already taken us there, but we hadn't really acknowledged it too officially or publicly yet, and that was our kind of coming out, hey, we're in the space, here's some customers doing some work with us. Today, what we have for you is a couple of clients who have built programs that have become very large and very useful in their area, and I think this whole notion of scale is a big deal. So how they get there, what's the journey like, that's what we're going to get into. As far as Zoom in telemedicine, we set out to build something at Zoom that would scale really well, right? You can get large super fast, would go B2C or B2B, it didn't matter, was relatively inexpensive, and was super simple to operate, and people like to use it. And then so it turns out, if you think about how medicine is changing from a doctor fixing a sick person to the concept of population wellness, those same things come back into play. So we go to our clients and what do you need? And they go, well, we need something that's really scalable. We need something that's maybe not just a connection to a hospital and a clinic anymore. It's got to go real wide. Therefore, it's got to be something that could go B2C as well as B2B. Can't be super expensive because this is going to be big now. And it's got to create a really good connection, because if people don't make a good connection on video, they're not going to use the service. And those are interesting parallels. Our mission as a connection company kind of turned out to be the same mission for a telemedicine offering. And that's a piece of the puzzle we play. We're a tool. We're not the workflow. Great people like this have built the workflow that we're so appreciative of. They've defined us in the space, really, and that's our starting point. So why don't I give Amber a chance to just introduce herself to start with, so the crowd knows who you are.
Sure. I'm Amber Humphrey. I'm the Director of Telehealth at Vanderbilt University Medical Center in Nashville, Tennessee.
And Dr. Hossam?
My name is Hossam Mahmoud. I'm the Medical Director and Senior Vice President of Regroup Telehealth. I'm also President of the Illinois Psychiatric Society.
So at this point, I thought I'd give Amber first a chance, I'm going to sit down here with you, to just kind of describe your program. This is something that you spent some time on, and maybe just give us the lay of the land in terms of use cases and what you're doing at Vanderbilt.
Sure. So we have a telehealth program that was centralized about 5 years ago. Currently, we have about 70 service lines who are doing some type of telehealth, whether it's live video or store and forward. Last year we did about 9,000 visits, and we anticipate that to grow year over year. We're growing at about 50% a year, but that's have some mature programs that have started to taper off, but we're looking at adding other things. So we really use video and Zoom specifically in 3 different ways. We have hospital partnerships. So Vanderbilt is a small health system. We only have 4 hospitals, so we're not like a lot of the larger, health systems with double digits. But we partner with community hospitals, either those in other systems or privately owned hospitals, to provide them with services that they can't provide in their own communities. And we'll talk a bit about that a little bit later. But then, so that's our system to system or hospital to hospital service. Then we do clinic to clinic. So we have regional traditional clinics that are Vanderbilt clinics that operate in person, but we also have telehealth capability at those clinics. We use Zoom for that inside of Epic. And then we also have direct-to-patient telehealth, which is ambulatory scheduled visits. So not your on-demand sick visit type thing, but scheduled specialist visits for post-ops or for chronic disease management, things in bundles or global periods. So those are kind of the three ways that we're using Zoom within Epic right now.
And you're leveraging the Epic integration that we delivered as well, right?
Yes, exactly,
Yeah.
which has been a huge. We could talk about that for 45 minutes,
We may.
at least. And Evan could talk about it like never again, probably.
Great. Thank you. And I think we have a video about your program. Let me see if I can play that and give the group an idea of kind of like the specifics of what this looks like.
Well, when you live in a rural community, in a rural area, healthcare is not the easiest thing. The rural farming lifestyle is very important to us, and we couldn't imagine living anywhere else. But we are probably over an hour to the nearest pediatrician. Ty woke up one morning with some swelling over his right eye. I wanted to be sure that if it was something that needed seen to, that he had the care he needed. So I asked Nurse Penny to look at it when he got to school.
So he came in and, I kindly recommend, I think it needs to be looked at. And so our conversation progressed to, hey, why don't we use our Vandy telehealth? And that's what we went with, and it worked out great.
The Allen County School District is one of the major focal points in our community. We are very proud of our buildings and our school system. But the educational process is nothing unless we have healthy children and kids where their personal needs are being met. So this will help our students in so many ways, it's immeasurable.
Anything they would use there at their office, we have the technology to give them that look from here to there.
The process was very easy. I received an email link, and I followed that link to join the teleconference. To think that I can have a physician evaluating my child while I'm sitting in my home office and I can participate in that visit is pretty awesome.
We got a treatment and everybody was on board and saw everything that went on, and within an hour we were done. I was like, well, that was pretty cool.
Time is one of our most limited resources here on the farm. I would highly encourage it to any parent because it allows them to continue on with their day and allows the child to remain in school.
Bear with me a second, okay. It must be really gratifying to wake up in the morning and know that your service was providing that kind of a storyline.
Yeah, it really is.
If you don't mind me asking, what specialties are available via tele?
So we at that particular school, it's just sick kind of general care because they have no pediatrician in the entire county. So the ED is their pediatrician. But we offered, a variety of in that same model with our specialty clinics. We're offering developmental medicine, autism, early intervention, which has been extremely popular, and just several other specialties for adult and pediatrics.
Thank you, Amber and Hassam. So how about a description of your program at Regroup Telehealth?
Sure. So Regroup Telehealth is a telepsychiatry company. We're based in Chicago. We were founded in 2012 with a mission to enhance access to mental health care across the country. I joined the company about almost 3 years ago, and it has really grown from a Chicago-based one-state kind of telehealth company. Now we're in 28 states. We have over 100 clinicians between psychiatrists, child adolescent, and adult psychiatrists, as well as psychiatric nurse practitioners, social workers, and psychologists that provide care at 150 sites across 28 states. Regroup contracts with healthcare facilities that are struggling to find psychiatrists or other mental health clinicians. And so the patients continue to come to their local healthcare facilities. So we're trying to eliminate that barrier to care that results from having to travel long distances and having to take time off from work to travel for maybe 2 hours to go to the nearest city and be able to get care. We are in freestanding mental health facilities, FQHCs, larger healthcare systems, correctional facilities, as well as really smaller healthcare centers and critical access hospitals. Last year we did about 100,000 sessions, and right now on a monthly basis we're doing over 10,000 sessions. So we are projecting by the end of the year to have completed 200,000 treatment sessions for patients. Yeah.
Boy, thank you.
Thanks.
I met Regroup at a show we were working. I didn't realize what they'd done with our product, actually. They've taken an integration different than Epic. They have an API integration where they've built workflow around Zoom. And they told me they're doing 10,000 encounters a month. I said, what? Wow, I had no idea. I thought that was just phenomenal.
So actually we use Zoom in different ways. At least in my mind, I conceptualize it as clinically and operationally. So from a clinical perspective, we've developed a HIPAA compliant platform based that is Zoom-based, it's API feature. And we use that to provide direct patient care as well as doc-to-doc consultation services, supervision of psychiatry residents, collaboration with nurse practitioners, as well as journal clubs and group peer supervision. So that's our platform, which we'll show you in a second. But we also use Zoom on a day-to-day basis for our meetings because many of our employees are actually remote. We use Zoom in order to interview candidates, both for HQ as well as clinicians. We use Zoom in order to do presentations for sales. And finally, we use Zoom for webinars, which is the most amazing tool I've ever used before. We've been able to put together a series of webinars that have been very, very valuable, both from a branding perspective, thought leadership perspective, but also kind of marketing. So yeah.
Awesome. Yeah, thank you. I think we've got a video of
Sure.
yours as well, right?
Yeah.
And understand that I'm told that there's less people going into psychiatric medicine all the time. So you must be filling a void.
Yes, so there is an extreme shortage of psychiatrists, but what's also challenging is that uneven distribution of psychiatrists. So they tend to be in larger metropolitan area, and so what we do is connect them with patients that otherwise wouldn't be able to receive care or who would have to travel so long to get care.
Terrific. Let's see.
Hello, and welcome to Regroup Connect. Regroup Connect is Regroup Telehealth's proprietary HIPAA-compliant virtual care platform built specifically for the delivery of mental health care services. Once you are ready for the patient to be seen by the clinician, click Request to initiate a session. Once you've requested a session from the patient room, your Regroup clinician will be notified of the request. Once the request has been accepted, the video session will launch on both sides, and the patient and clinician will be connected. In the video conference, natural communication is made easy with clear video and sound, making it feel as close to an in-person session as possible. Regroup Connect's video conferencing is private, secure, end-to-end encrypted, and offers consistent, reliable performance for optimal experiences for both patients and staff. Once the session is complete, your Regroup clinician will close out of the video conference. With a clean layout and straightforward navigation, we've designed Regroup Connect to be simple and easy to use for both users at our partner facilities and for Regroup clinicians, giving them more time to focus on patient care.
Really great work in an underserved market. Since our theme is getting something to scale, maybe both of you could comment on what you had to think about considering that you were going to do a large program as opposed to maybe a small use case. Amber, what was on your mind?
Sure. So 3 or 4 years ago, we were at a point where we realized we wanted to scale our telehealth program, but we didn't have the infrastructure to do it. And we had an older enterprise level version of another software that was going to need significant updates, but we also had our eye on transitioning our homegrown medical record to Epic. So lots of financial implications, lots of health IT resources tied up in preparing for that Epic leap, as we called it. And so we looked at Zoom, honestly, initially as an interim solution for doing some video visits outside of the EMR. And then we were going to wait to see how Epic would, what the capability was and what their recommendations were for integration. And at that point, their recommendations really were full integration with very expensive vendors, et cetera. But as we got closer to going live with Epic and then rounding back and having conversations, we were pleasantly surprised to see that Zoom was an approved vendor to do context-aware links. And the capability that we could have by doing that was actually better than the capability of some of those deeply embedded programs. So being able to share screens and pan-tilt zoom and those types of things that often get lost when you do that deep integration were available through Zoom. So it really just became an obvious choice for us to use to scale telehealth, and we've been really happy with it. And we often hear, just as you had mentioned, we're using Zoom in other ways, not just to care for patients. So when you go to a provider and say, hey, do you want to start using telehealth? We use Zoom, that's our video platform. Oh yeah, I use Zoom for webinars, or I use Zoom to talk to my colleagues at XYZ University. So they're very comfortable with and familiar with Zoom, and so I feel like that is an added kind of reassurance when you're getting ready to do something that I already know that the tricky part of the technology is something I'm already familiar with, and that does improve the buy-in for scaling telehealth across the organization. But to go back to, I think, your original question, what are the things we were looking for? Obviously ease of use, but with that enormous investment that we were getting ready to take on with Epic, we needed something that was affordable. And so Zoom absolutely checked all of those boxes and then some.
I know it's never simple to build something. You had to build workflow, although the end result sounds pretty simple. I mean, we think the whole industry is evolving from complex solutions to what really come across as more simple, almost consumerized deployments. Does that resonate with Vanderbilt?
It does. We decided to use Epic on virtual desktops, and so that added a layer of complication that nobody really understood or expected at first. So Epic and Zoom and our health IT spent a lot of time together, weeks of conference calls trying to figure out how to configure everything just right. But then to the physician, they were absolutely thrilled when from their whiteboard or their schedule, they could click on the video icon and you would launch a Zoom session. So once people saw it, once the end users saw it, they were so excited. But it did take a lot of work because of the way we have Epic configured.
To get it there, yeah.
Yes.
And Hassam, 10,000 encounters a month, that's a lot.
Yeah.
So you had to obviously, I would imagine, be thinking through things that were different for getting big scale. What was on the mind of
Yeah,
the group?
absolutely. I mean, first, I would echo your points about our experience with Zoom. The challenges that we had are being able to develop a software that would be easy to use regardless of settings. So since our partners range from very well-funded, very kind of sophisticated, large healthcare systems to very small kind of critical access hospitals that are very underfunded, or freestanding mental health centers, or Native American reservations. So we needed a solution that was very easy to use, where you can train your staff within, 5 minutes on how to use, and that is reliable, that is efficient, and that is HIPAA compliant, of course. And so that is why we decided to go with Zoom and build on your technology. I would say that is Yeah, that's kind of the challenge that we had. Now, we did not attempt to integrate into any EMR because we work with tens and tens or dozens of EMRs, and so that is not feasible with our business model. However, it's if a partner of ours has it, we're more than happy to use it. So far, we've been providing the technology, though, and therefore we use our platform.
You mentioned some environments that sound like they might lend themselves to not having the greatest bandwidth connections and unpredictable.
Correct.
How
Yeah.
have you found the connections?
You know, we do work closely with our partners to help sometimes enhance connectivity with hotspots when possible, but we really found Zoom to be reliable even when the connectivity is not perfect, which is amazing. Yeah.
Yeah, great. So staff of your own, you mentioned the doctors kind of embraced it pretty quick once the hard work was done and you presented something to them. What about it just in general with staff for both of you? In the journey to get from here to there, and now how's the staff reacted to the program?
For us, I think the staff, the nurses find it really easy that it's embedded within our EMR, so they don't have to think about it. It's not another site to log into or something else to monitor or get ready before a patient visit. We've really tried when we're offering telehealth to patients, because you can't make them do it, they need to be given a choice. We try to make sure that the schedulers and the people who are having those conversations with the patients really understand what a telehealth visit is. And for the way we've structured telehealth in Tennessee, because of the laws, many of the visits have to take place in an originating site. So we want that verbiage for the staff to be, we want to make this as much like an in-person visit with your doctor as possible. So you're going to come to one of our clinics, you're going to be placed in an exam room with video equipment, and instead of the physician knocking on the door and walking in, they're going to come to you on this video screen. But we really want the schedulers, the staff, to understand what that experience is like for the patient, so they don't undersell it, and that's been a learning curve for us.
Setting the right expectations.
That's
use a
right.
care coordinator to help with that? Is that when
We
you
don't
say?
have a centralized care coordinator.
Okay.
So what we do have is we have schedulers in each of the specialties that have these conversations with the patients. But we were at one point we monitor our volumes, and we were seeing that this one particular nurse practitioner was just really seeing a lot of her post-op patients, via telehealth, but we couldn't see on the Zoom dashboard. It didn't really look like that. And so when we started talking with her schedulers, the people in her office, when they were offering telehealth, those patients were saying, well, I don't want to be recorded. I don't, and so you have to explain, we are not recording anything. This is a secure video. It goes away when you're finished. But those patients were saying, the schedulers were saying, oh, you can do this on your phone. And so they automatically think phone call, not video. And then when you talk about video, they think about recording. So you really have to make sure that your patient education and the scripting to the patients is so clear, because if it's not, it will be easily misconstrued to recording and lots of other things.
And Hassam, so you have a big group of doctors that you're using for this service, and they sound like they're really spread around. They're not centralized. They're not necessarily under your command and control all the time. How was it to bring them into the service, and how do you get them to be comfortable?
Yeah. So we start off in the interview process. There are several rounds of interviews as we vet the doctors before we hire them, and we do have a lot of discussions about technology. A lot of them are seeking telepsychiatry because of some of the advantages, either related to lifestyle or to the area they live in, or some kind of flexibility to be able to maybe address aspects of your personal life. So there are definitely a lot of advantages. And so when we do start the conversations early on, we explore their comfort with technology, with utilizing different EMRs, but also with utilizing different kinds of technologies. And we still do some training, which is becoming less and less necessary just as people become more tech savvy. But when we're doing the training, we emphasize two components of the technology: the perceived ease of use, and so we demonstrate as to how easy it is to use both our platform and Zoom, because we utilize both during the training. And we also emphasize the perceived utility of the technology as well. And these are the two components that have been found to be very critical when we're talking about technology adoption and comfort with technology. We do the same thing with the partners in the healthcare facilities that we provide our services at, particularly with the telehealth navigators, as well as the behavioral health director or the mental health director in the site where we will be providing care, because we want to ensure that as we're introducing new workflows, there is buy-in from the site, because that is key to the success of the program.
And you've got kind of a three-way
Yeah.
deployment going
Yeah,
there.
exactly.
Right? Between the
Exactly.
provider,
Yeah.
the doctor-patient relationship, and your company.
So we orchestrate a bunch of meet and greets. We do dry runs for the technology with both
Yeah.
parties, with the three parties at the same time. So we're, we do a lot of dry runs to make sure everything is working well and that everyone's comfortable.
Amber mentioned setting customer expectations.
Mm-hmm.
How about in your world? Do you find that you have to draw them in, or?
I think the challenge that we face has to do less with the technology itself and more with kind of certain misconceptions about telepsychiatry overall, as to whether it's as effective or whether it has been proven to have positive outcomes. So these are some of the kind of challenges that we encounter, and so there's a lot of education that goes on during the discussions before signing any agreement to work together about just the benefits of telepsychiatry, if there are any drawbacks, what patient populations it's appropriate for or not. It's less about the technology we find. I find that the healthcare facilities we work with are very happy to let us kind of deal with the tech, and as long as we emphasize that we're not recording anything, we're not holding any protected health information, and patient's confidentiality is protected, that it's HIPAA compliant, they're fine with us kind of being in charge of that component.
Great. Can you quantify outcomes? And I'm curious, were there any unintended consequences now that you're sort of deep into this, Amber?
You mean take that one first?
Sure.
Okay. So we don't have any published outcomes as far as, the clinical outcomes, but we do survey our patients, and so we're very intentional about asking them about their experience. Some of the questions, we ask them about 10 questions. Could you hear the provider? Could you see the provider well? Was this visit as effective as an in-person visit? And we get extremely high response rates and
Functional
satisfaction.
Yeah.
Exactly. Would you recommend this to a friend? Do you feel like you could make a connection with your provider on video? And some of these are new patients, so it's not just a return visit with an existing relationship. They're actually building relationships. And we had one woman who has exclusively seen one of our endocrinologists by telehealth, and she said it's wonderful, and she absolutely loves it. But one of the other questions that we ask them is, how much time did you save by doing a telehealth visit versus coming to a traditional site of care? And these patients are reporting anywhere from 2 to 8 hours of saved time, which is significant, right? So I don't know how many of you are familiar with Nashville, but it's growing faster than our transportation infrastructure can expand. And so there's a lot of traffic. There's always been, but it's getting worse. And patients from these rural communities are overwhelmed by that and really don't like getting in the traffic, much less navigating a large medical center and the parking garage and all of the things that you have to do when you come to Nashville for care. So that 2 to 8 hours is a significant savings to them. They report that. We've heard things about how my family member who wouldn't have been able to take off work and join me at this visit was able to join me because it was right down the street from our house. The transportation costs, the gas that we've saved has been really helpful to my family. So we get a lot of good feedback about how much patients appreciate the service.
Nice.
Yeah.
And outcomes.
Sure.
Storylines on your side, Hassan?
I have two examples. We partner with OSF Healthcare, which is a large healthcare network in mostly rural Illinois, but also in Michigan. They have reported actually a 75% decrease in wait times for patients to see a psychiatrist, which was kind of mind-blowing for me. We do collect data. Actually, the data was presented in a poster a few months ago, and I'm happy to share a link to this poster for anyone who's interested. We did collect data from patients as to whether they were satisfied with having their session via video, whether they felt heard and understood by their psychiatrist. We also provide other services such as e-consults and doc-to-doc consults to that healthcare system. So we collected information about satisfaction with the service and its utility, and the responses have all been either satisfied or very satisfied in the upper 90s actually, which again, I'm happy to share this data with you. With regards to some clinical outcomes, so we don't hold any of the data, so everything I'm able to report is based on what is reported to me and what I'm allowed to share as per the healthcare facilities. So with OSFIM, with one of our other partners that's value-based care, they've been able to track ED visits and inpatient hospitalizations for their patients, and their ED visits went down by 37%, and inpatient hospitalizations by 24%. I'm unable to share the name or more details about that partner, but we are getting more and more of this data that's very valuable, and it shows that despite the fact that there might be an initial kind of increase in costs when implementing telepsychiatry services, the long-term savings are really very significant, somewhere usually between 40 and 60%.
And I think it's not just the savings to the particular organization or to the patient, right? So as you were telling that story, I'm thinking about our hospital-based services that are where we know the patient's disposition at the end of the consult. And so we recently started a teleinfectious disease consult service at a hospital that's about an hour and a half away from Nashville. And when I asked the physician, how are things going? You've done, several consults now. Prior to this service being available at that hospital, how many of those patients would have had to come to Nashville, Vanderbilt specifically, a higher level of care, because they had some infection that the hospitalist didn't feel comfortable taking care of, or maybe they had a complex disease that really just needed some extra support. And he said about 50% of the patients would have come here. So that's an amazing cost savings. When you think about it, it's better for the community hospital because they're getting to keep a patient. They have financial ramifications when they do transfer patients to other facilities. It's better for the patient because it's always better to be closer to home when it's clinically appropriate. And then the payers are also benefiting from this. And so this is the soapbox that I have to stand on for most of my job. But it costs less to take care of the patient in the community hospital than it does at the tertiary quaternary care center. So there are lots of stakeholders who are saving money in this scenario. It's not about the clinical. It's not just about the clinical outcomes. And so we're constantly trying to educate lawmakers and payers about the benefits of using telehealth.
Actually, we've had, over the past few months, we've had several payers reach out to us in order to enhance network adequacy and contain costs because of providing primary psychiatric care on an outpatient basis is so much less costly than providing even 1 day of inpatient services and the cost of that.
And I think that's true. You're in a very good situation that payers feel comfortable with behavioral health and telehealth. And so being able to demonstrate that people aren't overutilizing the service, that it's saving money in the long run. We're reducing ED visits and all of those crises, I think spills over to other types of medical care that hopefully payers will recognize this is a value, it's a cost savings, it's better for the patient.
You're both describing a lot of winners. I mean, and first and foremost, the patient's a winner. The physician can see it as an advantage to their lifestyle and the way that they go to market as a doctor, and the institution is becoming more efficient and kind of systematically, including the insurer and the whole ecosystem. Mm-hmm. So just one more question from me, and then I'll turn it over to the audience. Where do you think this is all going? And that's a hard question, but if you had to narrow it down to a thing or two, where do you think this goes in its evolution?
it's certainly not going away. It's only going to become more of a way to care for patients, and that's what we all have to start thinking of is telehealth is not a standalone service. You don't have this just group of telehealth physicians. It's another way for providers to provide to provide clinical services. And so I was just on a call before this about where are we going to put our next telehealth clinics, and we've got 3 markets in mind that are underserved that we would love to be there. We know patients are coming from there, and so I think a lot of what will happen will have to do with what the state laws are around licensure, what the payers are going to do with reimbursement, where they recognize as places that you can get paid for telehealth. I see lots of people nodding their heads because they know about originating sites and all of these other things that we have to navigate. And so I think that once CMS specifically loosens their regulations on reimbursement, I really think it's going to take off. But there are so many great examples of not just video, but remote patient monitoring, really being able to help patients leave the hospital sooner, reduce readmissions. All of this great data that we're starting to collect nationwide really points to that this is going to become the way that patients seek their care. Consumers want this, right? We know Teladoc and Amwell and Doc on Demand and all of those other places. They're capitalizing on, maybe that's a strong word, but they have recognized that patients want that Amazon experience for their healthcare, right? And so we have to make sure that we're as health systems ready to provide that as well,
More
because
consumer-like,
somebody else will.
accessible, equitable. Yeah.
That's right.
And Osam, what do you think?
I absolutely agree. I think telehealth is here to stay, and it's only going to expand further and further. Just a few months ago, Massachusetts became the last state to actually expand access as part of its public option to reimbursing telehealth services. And so now we have all states, including the District of Columbia, reimbursing for telehealth services. And in addition to Medicare, we are expecting Medicare to expand coverage as well. That's partly driven by wanting to combat the opioid crisis. There are some restrictions on e-prescribing as well from the 90s that we think are hopefully going to go away soon. So, and then the last, well, not the last, but one of the other major hurdles was licensure across states, which is getting easier and easier with what's referred to as a compact. In kind of every few weeks, a new state is added to the compact. So I see telehealth and telepsychiatry just scaling and moving forward, yeah.
The barriers are definitely coming down slowly. We
Yeah.
have been having this conversation for 10, some organizations have been having this conversation for longer, but we're starting to get, I think, incremental wins.
Great, terrific. So questions from the audience. We'll have a mic passed around.
Hi, my name is Paul. I'm from Stanford University. I was curious in terms of the nitty-gritty of, first of all, supporting technical issues during the calls, how that's handled and how that gets passed off between whom and what organizations get involved. And then second part is, you mentioned the post-meeting surveys and how you integrate that into the actual meeting experience and post-hand what happens. How do you collect that information? Do you use specific tools? Because from our experience, the current integrated or the current built ecosystem within Zoom is fairly limited, so you have to potentially integrate other tools and systems. So thank you.
I can't. Did you say you were from Stanford? So we're actually trying to get a hold of you guys so we can ask you the very same questions. So don't leave.
Okay.
I will say that we use video within MyChart, so the patient portal, and our health IT folks were very nervous about just having this like floodgates of calls once we started having video visits through MyChart. They were very nervous, and so it took a long time to be able to prove that we don't need that much additional MyChart support for patients, because patients are calling to get their passwords reset. They're not necessarily calling because their video visit doesn't work. So that's been something that we've been able to disprove, that the help desk calls are not overwhelming, which is a good thing. Our survey tool that we use is RedCap, and so it is not integrated into the visit at all, which is okay. So we send that out via email after their visit, so we don't actually get like current feedback. But if you look at how Press Ganey and those types of organizations do surveys, they don't necessarily want you to survey the patient while they're still there. I think there's some bias associated with that. So we're getting pretty good response rates on the tool that we have.
Yeah, sure. So we have a 3-person IT department, and there's virtually no downtime when it comes to Zoom. So they are able to manage any issues that come up, and they do typically end up being resetting my password or something wrong, my laptop froze or something of the sort. With regard to the surveys, we are actually, through our platform, we're able to customize surveys to what the healthcare facility would like to ask. The kind of questions vary so much. Some of them are, did you like your doctor? It might not be related at all to tele, but some of them are, did you feel that you were able to communicate easily? Were there any issues with video? Did you like the session being via video? And so we're able to customize them, and because we have 150 sites, they're virtually unlimited combinations of questions. But that goes through our platform.
I would add, on the tech side, what I've observed over the last few years is really what customers are guiding us to is less is more. Where the more complex programs, which were really the only way that we could get it done 5 years ago, that you can't scale that, it's hard to do something that looks like population wellness that way. So the more simplicity we can bring, the better. Epic has kind of helped with that in their case, because they've drawn out their suite to be more of a telemedicine encounter without a lot of third-party work. So less is more does seem to be a guiding post for what we hear. I had a question in the front here.
Yeah, thank you. Appreciate it. My name is Dan. I'm with UCSF. This question is, I guess, specifically for, I apologize, mispronunciation ahead of time, but Dr. Mahmoud. Yes. I specifically, now this might be too technical a question, I apologize, but you stated that as far as your patients facing staff, you have it separated from your, I guess, organization staff as far as video calls, HIPAA compliance versus non-HIPAA compliance. Did you say that? Like it was separate?
So when we use our, it's all HIPAA compliant. So regardless of what version of Zoom, what feature we're using, it's all HIPAA compliant. Okay. What I stated was that we use the platform, our own proprietary platform, that is Zoom-based, for providing the sessions, whereas we use the kind of more, dare I say, generic version of Zoom for training staff or training our clinicians.
Okay. I didn't know if you had split it out on the groups, sort of, that sort of thing on the back end.
Yeah, no, we didn't.
Okay.
No.
You can, so
Yeah,
it's possible to create
subgroups
that way.
I was kind of curious if anyone was worried about stepping outside of the HIPAA compliance, but it sounds like you're playing it safe, just like we are as well. So,
yeah.
okay.
Emory talked about that this morning,
Thank you.
right? How they've kind of segregated their groups.
Yeah, we have a couple more questions we can take. Go ahead.
Hi, my name's Wilson. I'm a licensed marriage and family therapist and also addiction counselor. So in the context of stigma, and then also states have higher requirements on time to access, and also our demographics are getting older, so mobility is going to be a challenge, and we're talking about scaling out. So I wonder if the idea of going into the patient's home or more community-based services, is there something that in your roadmap, do you envision that? Or is that going to be something like, because of all the challenges, technology will be like way further down the road? I'm just curious where you're at in that regard.
I can start.
Sure.
Yeah, we definitely envision that. There are some challenges at this time that have to do with providing care directly to the patient's home. Some have to do with laws and regulations about prescribing certain medications. So we can't prescribe controlled substances if the patient is at home. They need to be physically at a DEA-registered facility at the time they are seen. So that has been a restriction, particularly when it comes to ADHD in children. The other restriction is reimbursement. Medicare, right now, they only reimburse for services when the patient is physically located at a county, at a healthcare facility in a county that's either designated as a shortage county or a rural county. And that's something that can be actually found or researched ahead of time. But because of that restriction, we haven't been able to expand the services to the patient's homes. This is likely to change with Medicare, particularly if the patient has a diagnosis of a substance use disorder, regardless of what other treatment you're providing. So these have been the challenges that we face when it comes to scaling services direct to patients.
I know some of our psychiatry colleagues are nervous about not having the patient in a qualified site just in case there's a crisis, and not being able to get to that patient quickly enough. But for stable patients who are just going through some ongoing treatment, we have some pretty good success there.
We're reaching the end of our time with we can do one quick question to wrap up.
Hi, Chris Harrett from SBR Health. We do integrations between Zoom and various EHRs. So just curious to ask both Amber and Hassam, what are you missing in terms of features or functionality you'd like to see either from Zoom or Epic, or the integration of those two, or the APIs that you're using?
That is probably more technical of a question than I can answer, because the way that we use Zoom at our organization is the same outside and inside of Epic. The functionality is there, so we're happy. We're looking very forward to the natural language processing and those types of things that will be added, but we've been pleased when you compare it to other fully integrated softwares.
Yeah. At this stage, I'm very pleased with the products that we're using. Our IT department might have a different answer. I look for, but they're not here. I do look forward to a time where we're able to integrate some interpreting services as we try to service patients who don't speak English. Yeah, so that's the only part that I can think of now.
So we do want to say thank you to all of you for joining. We have a thank you gift for our two presenters. Amber?
Thank you.
Hassam?
Hey, thank you.
I'm racing off, speaking of interpretive services, to another breakout that we will cover that topic.
Oh, okay.
And thank you both so much. Thank you all for joining us. I think our two presenters might be able to be around for a few minutes after outside the room. And thanks again.